Good morning, good afternoon. My name is Andrea Hawkinson, and I am the Global Medical Affairs Lead for the Metabolic Health category with Nestle Health Science. And I'd like to thank everyone for taking the time to join us today for today's webinar in recognition of World Liver Day, titled Non-Alcoholic Fatty Liver Disease, Sustained Weight Loss and Improved Liver Health with a Very Low Calorie Diet, which will be presented by Dr. Rajat Mahal and Dr. Jadine Scragg. Dr. Mahal is a professor of medicine at Yale School of Medicine and director of the Yale Fatty Liver Disease and Weight Loss Programs. His clinical training is in liver diseases, and he also directs an NIH-funded basic science laboratory that examines mechanism of liver steatosis, inflammation, and fibrosis. For today's presentation, Dr. Mahal will discuss the pathogenesis of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, the proposed new terminology for NAFLD, and some of the current treatment recommendations with focus on weight loss and improved outcomes. Following Dr. Mahal's presentation will be Dr. Jadine Scragg, who is a researcher at the University of Oxford with research interests in trialing interventions for the management and treatment of obesity-related diseases. Her research is focused on assessing the potential utilization of lifestyle therapies as a means of treating and managing liver disease, which is the focus of her presentation, in which she will discuss the findings of treating and managing liver disease. She'll discuss her presentation. She'll discuss the findings and implications from her study, feasibility of a very low calorie diet to achieve a sustainable 10% weight loss in patients with non-alcoholic fatty liver disease, for which she was the lead investigator. This study aimed to evaluate whether a very low calorie diet is an acceptable and feasible therapy to achieve and maintain a greater than or equal to 10% weight loss in patients with clinically significant NAFLD. After the presentations, we'll have a live Q&A. So if you do have questions during the presentation, please post them in the chat box and we'll try to address them following during the Q&A. Before I hand it over to Dr. Mahal, I would like to make the disclaimer that this webinar is being recorded for educational purposes only. Now it's my pleasure to hand it over to Dr. Mahal.
Thank you so much. I'm just going to start sharing my screen with you. Can you see my slides?
Yes.
Okay, great. Okay. Well, it's really my great pleasure to be able to join and present at this webinar on this very interesting topic of non-alcoholic fatty liver disease. So I'll jump right into it. Initially, what I would like to do is for about 5 minutes or so is to give you some background as to the nature of this disease, because it is a relatively new disease for all of us to come to grips with. And this disease is really a disease of metabolic derangements, and its terminology is broken down into sort of two broad groups. One is the umbrella term of non-alcoholic fatty liver disease, or NAFLD, which is primarily characterized by steatosis in the liver exceeding a certain amount, sort of 5 to 10% of fat-laden hepatocytes. And then a subgroup within NAFLD is non-alcoholic steatohepatitis, and the hepatitis really refers to inflammation and injury of hepatocytes. On the left there, you can see the histology of a normal liver, and the arrows there are pointing to really hepatocytes, which are lined up sort of in an array. And with increasing nutrition and metabolic derangements, what happens is that these hepatocytes begin to fill up with lipid droplets, as you can see here, the white here. So each one of those white circles is a very large droplet of lipid, predominantly triglyceride, inside hepatocytes. And you'll commonly see an arrow going from the normal liver to the steatotic liver. And I would just like to point out right at the get-go is that this is a reversible situation. So really, we should think of this as a reversible situation. Now, with time and in a subgroup of patients, this can result in not just steatosis, but also inflammation. And it's not very clear here, but there are many little dots here of inflammatory cells. And this, at this point in the bottom left, there's actually injury to the liver and death of hepatocytes. And over a period of time, this can actually result in fibrosis and scarring. And that is seen on the right-hand bottom corner with the blue stain. So these are the sort of different stages of progression and regression of this condition. In terms of where this fits within the overall spectrum of liver disease, if I were to show you the spectrum of liver disease, say in 1980, we had a grouping of autoimmune conditions up here. I won't go through them individually. We had a grouping of genetic conditions, Wilson's disease, hemochromatosis. And although hemochromatosis is not rare, the phenotype fortunately is rare, although the genetic abnormality is not rare. Alcoholic liver disease has always had a very significant footprint in society, which still exists. And of course, there were viral hepatitis, hepatitis B and hepatitis C, which are decreasing now. And if we wind the clock forward to today, there's a huge footprint of these conditions. So NAFLD, as I said, is the umbrella term, which affects about a third of the population, certainly in developed countries. And then NASH, which is a subgroup with actual injury to the liver, and that is still a significant number of individuals. It's somewhere around 6 to 7%. So as you can see, over a period of a couple of decades, there's been a remarkable transformation in the resurgence or the surgence of these conditions. This is not limited to just, I'm in the US, but this is not just limited to the US. And here are the figures for NAFLD and NASH from a number of countries. And then in the bottom, there's data from China, where both these subgroups are actually on the increase as well. And again, really demonstrating how they correlate with industrialization and populations moving to a city and urban sort of a lifestyle. I'll take you through this graph at the bottom. If we just focus on the left-hand side initially, what this shows is in blue, it shows us the number of people with steatosis, and then in red are the individuals who have injury on top of that. And the numbers in the US are approximately little over 80 million. And this is the projection for 2030. And we can see that there is an increase, but perhaps one may say is not a remarkable increase, going from 83 million to 100 million. However, this breakdown here actually shows the number of people who have different stages of liver fibrosis, with F4 being the most severe and commonly called cirrhosis, which is approximately 1.3 million at the moment. And we can see this increases substantially to almost 3.5 million. So this really is it's already a major disease, and it's projected to result in even more health issues for the population over the next 10 years. And this is just to point out and remind me as well that NASH doesn't just bring with it fibrosis. This is data for HCC, which is liver cancer, hepatocellular cancer. The dots and squares are actually data points, and then the rest of the lines are projections. So as you can see in blue, this is HCC due to hepatitis C, and this is HCC due to NASH. And around about now, there's a transition with hepatitis C causing less HCC, but NASH being the predominant reason for liver cancer. So this disease actually has a number of impacts, and I'm just mentioning one, but there are others as well. So the point here I was making is that actually not only is there an increase in the population for NASH, but if you look at the black line, which is the younger population of between 18 and 40-year-olds, that's where the greatest increase took place. Okay. And Andrea, if this were to happen, please send me an email or call me, because obviously while I'm looking at the slides, I cannot tell if the Microsoft thing is not working. So that's obviously a major concern, because this means this disease is not going away anytime soon. If anything, the numbers are going to increase. Other sort of general clinical features are that not only are patients obviously having the disease, but first-degree relatives of patients with NAFLD and cirrhosis are actually 12 times higher risk of advanced fibrosis as well.
Dr. Mahal, we can't see your slides, so I think you need to reshare.
Oh, I see.
My apologies.
No, of course, that makes sense. Since I disconnected. The share window. I don't see the share button right now. Oh, here we go. It's in a different place. Okay, can you see my slides now?
Yes, we can. Thank you.
Okay, great. Okay, so I'll just backtrack for just one slide. So the point here I was making is that if you look at this black line, not only is the overall incidence of NASH going up, but this black line represents the age group between 18 and 39, the younger age groups compared to the other two lines. And that's where there was the greatest increase in the incidence of NASH. So this disease, unfortunately, is not going away anytime soon. And not only, of course, are patients affected, but actually their first-degree relatives have a much higher, approximately 12 times higher risk of advanced fibrosis. And there is actually a racial difference in incidence of NASH as well as advanced fibrosis, with individuals with a Hispanic heritage having the highest risk, then Caucasians and African Americans. So what are we seeing in clinic? What does this feel like and look like in clinic? So this is a typical patient that I saw about approximately 3 months ago, 52-year-old attorney, 5'9", 205 pounds, BMI of 30, mild, little alcohol, social alcohol, mild hypertension, and overall feels perfectly fine. However, it does have mild elevations in AST and ALT, which is commonly seen, but other laboratory values are fine. Then when we actually go ahead and do a full workup, we find that this individual actually has stage 3 to 4 fibrosis, with stage 4 fibrosis being cirrhosis. So, this is a catastrophic diagnosis for somebody who felt that they were generally well, to be told actually they have cirrhosis. And we're seeing this again and again and again. And personally, the youngest person I've seen and diagnosed with cirrhosis was only 31 years old. So this is, the denominator is huge, but the numerator of meaning people who have, fibrosis is also significant, very large numbers of individuals. So as a general overall background, most NAFLD and NASH is subclinical. Patients don't have very high BMIs, around about 32 is average. And insulin resistance and metabolic syndrome are really the better predictors of risk rather than just a BMI number. Many patients can be identified with elevations in AST and ALT, but the sensitivity is quite low. And unfortunately, many patients are already presenting with fibrosis and cirrhosis. And we know that progression of fibrosis occurs in 15 to 20% of people over 3 to 5 years. Now, in terms of clinical workup, the individuals who present with steatosis and elevated LFTs, we sort of have a set of reflexes because, we've been managing patients with elevated LFTs because of hepatitis C and hepatitis B. The people who present with steatosis and normal LFTs are actually a much bigger clinical challenge because the numbers are so large. So this slide is to make the point, and I've mentioned it briefly already, that the metabolic syndrome is key to this disease, and it's not all about the BMI. The average BMI of patients with NASH is approximately 32. Central obesity is a crucial risk factor for developing NASH, as well as other features of metabolic syndrome, such as diabetes and high blood pressure and dyslipidemia. There has been a very strong and concerted move to reorientate the disease towards this. So often this is referred as a change in terminology from NAFLD to MASLD, the M standing for metabolic dysfunction associated liver disease. And here the criteria would be, steatosis plus a functional feature of metabolic disease, diabetes, metabolic dysregulation, etc. And this actually is a lot more than just change in terminology. This actually is an entire change in definition of the disease. And what I'd like to share with you here is data from the NHANES study. I won't go through all of it. The main point I would like to make is that there's a huge overlap between MASLD and NAFLD in the real world population. This is not proportional. And the point to make is that the non-MASLD NAFLD population is only about 4.7% of the whole population, and the MASLD, non-NAFLD, if you like, is only 2.6%. So this is a change in definition, not simply a terminology issue. However, practically, the two populations overlap to a significant degree. This slide is to make the point that of all the features of fatty liver disease, it's the fibrosis that we worry about the most, because this correlates the best with actually liver-related mortality. So again, to remind you, F1, 2, 3, 4 are stages of fibrosis, with F4 being cirrhosis, And as the fibrosis stage goes up, the mortality goes up. And if I were to show you the same distribution with, say, steatosis or inflammation, there is not such tight association with mortality. So fibrosis is really what's concerning. And this, again, is actually showing you data for that. This is a survival curve based on individuals who are controls or with increasing amount of fibrosis, and you can see that the survival drops off dramatically, particularly as we move from F2 to F3 and F4 fibrosis. Can you still see everything, Andrea?
Yes, I can.
Okay.
Thank you.
Okay, good. Just checking, because otherwise I have no other confirmation. Okay. Now, this is, again, is sort of the same data, but it makes a slightly different point. This data is showing you the distribution of fibrosis in the overall population of NASH. Okay, and I'd first like to sort of bring you to the worst end of the spectrum, which is F3 and F4, which affects approximately 12% of the population. You know, keeping in mind that the NASH population is about 6 to 7% of the entire population. So we're speaking about 12% of 6%, which may not sound like a lot, but again, we're speaking about severe end-stage liver disease. But to me, the more shocking aspect is that if we look at this data and ask, of that 6 to 7% of the population that has NASH, how many have no fibrosis? It's only 20%, okay? So, which really is, to me, very alarming, because of course we worry the most about the people with cirrhosis, but essentially, you know, any fibrosis is bad news. And of that 6 to 7%, only 20% have no fibrosis. You know, so 20% or, you know, of 6%, which we're saying is about 4% of the population has some degree of liver fibrosis from NASH. And those are very large numbers. You know, what caused NASH, and we're still struggling to find out exactly the molecular and the overall basis for this disease. Obviously, we had two big surprises. One was the obesity epidemic. This shows you the change in the obesity distribution between 1990 and 2003 in the US. And of course, the mean BMI went up from 25.4 to 27.7, which is a huge difference in a population. But the other thing I'd like to point out is that what did not happen is that the whole curve didn't just shift to the right by, say, 2 BMIs. What happened is that the right-hand side of the curve splayed out. And these two red lines you see here are BMI 30 and 40. And just by eyeballing it, you can see how many more people have moved into this above BMI 30. This has affects, you know, major implications on a population level, but also just to remind you on an individual patient level that people who are overweight or obese are the subgroup who tend to put on more and more weight. Okay, so it's not that the whole population has just gained 2 BMIs. It is a subgroup of the population that has predominantly put on the weight, and that's a population we really need to focus on. And the second aspect is sterile inflammation. I won't be going into this in any detail, but just to point out that injury to tissues, whether it's traumatic injury, and this is showing you a normal myocardium, cardiac tissue, and this is myocardium 6 hours after a myocardial infarct, but tissue injury results in inflammation, and this process is at the heart of the inflammation we see in NASH, but I won't be going into that in any more detail. So I'd like to share with you some good news. And the good news is from this study, which looked at individuals who were in a very controlled clinical environment, clinical trial environment, were induced to undergo gradual weight loss. You know, starting obviously as a control group, as I'll show you, and then 5%, 11%, 16% weight loss, and then a whole range of detailed metabolic studies were carried out on them, including skeletal muscle insulin sensitivity, molecular cellular biology of adipose tissue, etc. I will just be focusing on the liver tissue because we don't have time to go through the entire data set. But an overview of this was identifying 40 eligible individuals. 20 were randomized to a weight maintenance group, and then the other 20 were divided into either a 5% weight loss group or a group that went through progressive 5, 10, and 15% weight loss, and then all these very detailed metabolic and molecular studies were conducted. And here is the data for the progressive weight loss group. So this is 9 individuals who have first become by dietary changes, undergo 5%, then 11%, and then 16% weight loss. And I will just want you to focus on the data on the intrahepatic triglyceride data. Initially, the triglyceride content was 8.5%, of the liver. At 5% weight loss, that dropped to 7.4%, and at 11% weight loss, that dropped to 4.1%. So for me, the good news and the take-home message from this is that with 11% total body weight loss, there is a greater than 50% loss of hepatic triglyceride. 4.1% is less than 50% of 8.5%. So there is a selective and proportionally greater loss of liver lipids, which is, very good news for our patients. Now, what about actual weight loss and fatty liver disease? This is a study from 2015, which enrolled 293 individuals, and they went through very intensive dietary coaching and advice with, weekly appointments, etc. And the reason I selected this study is that there was pre and post liver biopsy data available, which end up keeping in mind that the liver biopsy is sort of the gold standard for understanding what's going on in the liver. And then this is liver biopsy data. The NASH score is simply a histological score of inflammation and steatosis. And if they divided the population into those that had an improvement in the NASH score after a year, compared to those that did not, there was clearly greater weight loss in those that had improved their NASH score. And this is looking at fibrosis. And again, there was greater weight loss in the individuals who had either stabilized or regressed in their fibrosis. And when I say greater, it's worthwhile keeping in mind that the percentage isn't astronomical. We're speaking about sort of in the 7 to 8, 9% weight loss. We're not speaking about 20, 25% weight loss. This is the same data in a different, presented in a different way. And what this demonstrates is that basically the lighter colored boxes, the white boxes, show individuals who had worsening of their fibrosis, the dark gray who had stabilized, and then the light gray who had regressed in their fibrosis. And what you can see is that with increasing weight loss, essentially, nobody had worsened their fibrosis after a year when they had lost 7 to 10% weight loss, and greater numbers of people had regressed in their fibrosis. So again, the point being that even the fibrosis, which is the aspect that we worry about the most, does actually improve. Can you still see, Andrea?
Yes.
Okay, great. So this is my final slide. It's a summary slide. So NAFLD and NASH are on a spectrum of disease. Metabolic syndrome is the key risk factor. NAFLD is present in a very large number of individuals, 30 to 35% of the populations of many industrialized countries. And NAFLD and NASH may progress to cirrhosis and liver cancer. Stratification of patients here is a priority because the denominator is so large. And the key predictor of morbidity and mortality is liver fibrosis. And the good news is that moderate, meaning 8 to 10% total body weight loss, can result in significant improvement in liver histology and a proportionally greater loss, approximately 50% loss of liver fat. And that's my last slide. And Dr. Scragg will be speaking next. So I'm going to unshare. So can you just share, or do I need to unshare? Stop sharing. Okay, you should be able to share.
Thank you very much for that, Dr. Mahal. I will just hop straight in and share my presentation and slides. Okay.
We have an echo for you, Dr. Sprague.
Pardon?
I think there's an echo.
How about that? Is that better?
Still echo.
Is this any better?
Yes.
Okay. Okay. So I will just dive straight in. As Andrea alluded to earlier, I will be talking predominantly about a study which I led. It actually finished just over a year ago now. And that was a study very specifically looking at the feasibility of a very low-calorie diet to achieve a sustainable 10% weight loss in patients with non-alcoholic fatty liver disease. And the kind of primary outcome data of this study was published September last year. and clinical and translational gastroenterology. So I'll be talking, so if you have by chance read this paper, some of the kind of information I'll talk about will be fairly familiar, but I will also be talking and branching out a little more on the information that was in there and talking more about its, I guess, kind of clinical application potentially and directions further forward. So as Dr. Mahal said, I will not repeat his words too much as he phrased it very articulately, much more so than I can, but quite briefly, NAFLD and NASH is very prominent within the general population, affecting up to 1/3 of the general population, with up to about 1 in 10 of these people potentially going on to develop progressive liver disease and advanced liver disease. And this number is rapidly increasing. And with that in mind, there were a few kind of elements that led to the development, I guess, decision to conduct this study. So currently there are no approved pharmacological treatments for NAFLD, and weight loss through lifestyle changes is the recommended therapy. As again, Dr. Mahal mentioned, he talked a lot about the Villar-Gomez paper, which was the 2015 data he discussed. But it has been shown that weight losses of greater than 10% are indicated as factors in fibrosis resolution. However, in practice, few patients actually manage to achieve and maintain this magnitude of weight loss to 1 year. With that in mind, there have been a series of studies looking at total diet replacement, very low calorie diets in populations which likely have quite a large overlap with NAFLD cohort. Specifically, it's been shown to be effective to induce significant weight loss in people with obesity and in people with type 2 diabetes. So with that in mind, the aim of the study was to determine whether a very low calorie diet was an acceptable and feasible therapy to achieve and maintain a 10% or greater weight loss in patients with clinically significant NAFLD. And with that in mind, the primary outcomes was feasibility and acceptability of NAFLD, briefly defined as feasibility to recruit and actual retention numbers, whether or not it could be delivered faithfully, and percentage of patients achieving that 10% weight loss sustained after completing the very low calorie diet intervention. And there were a whole host of other secondary outcomes that we did look at, although it does need to be emphasized, I think, probably fairly early on, that this is a feasibility study. It was not powered to formally statistically look at most of the data I will present, but I am hopeful and optimistic that this data is very informational and is potentially great for informing further research, further studies, and for potentially informing some potentially clinical decisions going forward. And other things that we looked at as secondary outcomes were liver stiffness as measured by the FibroScan, which is transient elastography. We looked at absolute change in body weight, and we looked at change in clinical blood markers, in cardiac markers. In case anyone kind of watching is not too familiar, a Q-RISK-2 score is a score which is the likelihood of having a cardiac event within the next 10 years, and this is defined as a percentage, for those who maybe not be too au fait with that. And I also looked at parameters of type 2 diabetes risk, and that was parameters such as HbA1c, insulin resistance, blood glucose, and I also kept a bit of a track of any medication changes. On top of that, I looked at quality of life, which it has been reported previously in some studies with NAFLD that people with NAFLD may experience a lower quality of life. Some people think that this may be due to high levels of fatigue that they may, or likelihood is that NAFLD tends to be comorbid to several other things such as obesity or type 2 diabetes. And so therefore these people do often tend to have a slightly lower quality of life than, I guess, their healthy kind of counterparts. And we also looked at a series of non-invasive liver scores as well, which are, I guess, as is in the name, are non-invasive scores which have been validated against biopsy to formally kind of get an idea of where they are with fibrosis. The reason we did this is I, of course, did not do a pre and post biopsy for several reasons, the main one being that this was an efficacy and feasibility study to know whether or not that this was a suitable treatment. And there are a few other things I looked at, such as I started to kind of deep dive into whether the weight loss was associated with improvements in markers of liver health. So without further ado, I want to talk a little bit about the recruitment strategy, because given that this was a feasibility study and one of the key things I looked at was feasibility recruit, I think it's quite important to be aware of how it was that recruitment was undertaken. So we worked quite closely with clinicians, and indeed members of the CIs of the research team were clinicians who frequently have either general hepatology or fatty liver clinics. And therefore, these people that were recruited were identified for eligibility when they attended their regular NAFLD screening visit, or if they were first referred. Essentially, they were picked from these clinics if they're identified as potentially being eligible. And in terms of who we recruit specifically, we kept it quite broad. So we characterized this as clinically significant, and this was defined as imaging evidence of steatosis plus indeterminate or high NAFLD fibrosis score, or indeterminate or high FIB4 score, or histological evidence of NASH with fibrosis. These potentially eligible participants were identified in clinic, contact information was obtained and forwarded to members of the research team, and thereafter, if the potential participant did not make contact within a few weeks, they were contacted and I got their thoughts on whether or not they might be interested in taking part. And that meant that overall, within 6 months, the study was fully recruited with a number of 30 people. And again, just before I kind of dive more into the results, I want to talk a little bit about the safety monitoring, because again, this is an intervention which is perceived to be quite drastic to some people, so it is really important to talk about how we ensured safety of the patients. So all sulfonylurea oral hypoglycemic agents were withdrawn and the patient's GP was notified. Any other diabetic medication was continued as normal unless specifically instructed by one of the more clinical members of the research team. And we also encouraged participants to regularly monitor their glucose at home, and we regularly took glucose samples when they came to study visits. Similarly, blood pressure was monitored regularly and adjustments were made to blood pressure medication as required, but they didn't come off them as standard prior to partaking. And all the medications were continued as usual. When we're talking about a very low calorie diet, I think it's quite important to ask what is it we are referring to. So this was overall designed to be approximately 800 calories a day, and this was comprised of 3 meal replacement shakes a day. They had an option of flavors, and that came up to about 600 calories. And then the remaining 200 calories were largely made up by 3 portions or 240 grams of non-starchy vegetables per day. And we encouraged them to drink at least 2 litres of water and low-calorie beverages. There was also an allowance of 100 millilitres of semi-skimmed milk to put in any hot beverages. And the reasons that we did this, such as including the vegetables and giving that allowance, was to hopefully boost adherence and make it potentially a bit more interesting for them, particularly if these people do like cooking or did want that kind of satiation of eating. And this was done for a target of about 8 weeks. However, if we got to the 8-week point and patients were feeling comfortable and happy and wanted to, they could continue up to 12 weeks, so for a further 4 weeks. And after that, there was a step food reintroduction over a period of approximately 4 weeks, whereby for the first week, one of the meal replacement shakes was removed and replaced with a calorie-controlled healthy meal, and so on and so forth until they'd returned to a fully food-based diet. And this was done over about 4 weeks. And this is roughly what the study looked like. So we had 3 main data collection visits: baseline, post VLCD, and at 9 months follow-up. And throughout this, there were several interim visits. So it was at these visits, which, as you can see, were more frequent during the very low calorie diet phase, where we did the bulk of our safety monitoring, such as glucose and blood pressure and so on and so forth. But we also found, as I'll talk about a little bit later on, we also found that this was really useful for just keeping patients adherent and giving them any behavioural support that they might have needed. So this is a hugely busy table. I'm not going to dive into too much detail about this, but just to kind of pull out who it was that we recruited. So Dr. Mahal said that the average BMI of people with NAFLD is about 32. and the average BMI of the people recruited in this study was 42. So we definitely, I think, had maybe not a fully representative of your standard NAFLD patient, as we did have people who were had a higher BMI. And just of interest for a breakdown, so 47% of patients had a BMI between 30 and 40, 43% of patients had a BMI between 40 and 50, and 10% of patients had a BMI of over 50. 53% of patients had type 2 diabetes at baseline, and 43% had full metabolic syndrome. In terms of categorizing them by their NAFLD severity, all patients, as per the inclusion criteria, had either an intermediate, indeterminate, or high NAFLD fibrosis score, or indeterminate or high FIB4 score. 16 out of 30 had NASH with fibrosis on biopsy. However, again, just to reiterate, not all patients had a biopsy. Patients whose data we have on biopsy, it was simply they'd potentially had a biopsy as part of their diagnostic pathway and was not part of the study. And baseline liver stiffness, as measured by FibroScan, was 13 kilopascals. 17 participants had a liver stiffness measure of over 8 kilopascals. Of how the study went once we got going. Overall, in the first 6 months when we were recruiting, we assessed 45 for eligibility, of which 30 were successfully recruited. 15 were excluded, and 10 of those declined to participate for either other medical reasons or maybe not feeling it was quite for them, and 5 didn't quite meet the inclusion criteria. And then all patients received the intervention. It was not a randomized control trial or anything like that. It was a single arm study, and overall 27 patients completed the very low calorie diet. Of interest, 11 of those elected to take it up to 12 weeks, and the other 16 kept it at 8 weeks. And then 20 made it to the 9-month follow-up period, study completion. And the main reasons for diagnosis, there wasn't really any main reasons. They were quite varied. Often it was other health conditions taking precedence, or unable to commit to the study visits due to work commitments, so on and so forth. And when we're looking at weight loss, this was the main weight loss throughout the study. And this blue star here indicates data at post VLCD. So as I mentioned, 11 completed 12 weeks of the very low calorie diet, and by this point, 53% of patients had lost more than 10%, and mean weight loss was 11.3 kilos. Potentially unsurprising, but I think worth noting, those who completed 12 weeks of the very low calorie diet lost significantly more weight than those who completed 8 weeks. And right at the end of follow-up, where this green star indicates, 34% of patients had lost more than 10% weight loss. So of interest, this is using 30 as a denominator. So this is 34% of every participant that was recruited, regardless of whether or not they completed. So that's 34%. And mean weight loss was 10.3 kilos, which was the equivalent to about 8.9% of their initial body weight. And when looking at who this didn't work for, because at the end of the day, this was a feasibility study, there wasn't any largely characteristic definition of people who withdrew from the study. And as I said, main reasons for withdrawing were other health concerns taking precedence. So now I'm going to talk a little bit about the secondary outcomes, which I mentioned earlier on. Reminder again as well that the study was not powered to formally statistically assess these, but hopefully these are interesting and potentially can guide further studies down the line. So relevant to liver health, we looked at a series of liver enzymes, and they significantly improved from baseline to post VLCD, and that those improvements were maintained out to 9 months. There were no significant relationships between total weight loss and changes in liver enzymes over the study period, and I'll talk a little bit about that later on. Quite interestingly, we can see that particularly with AST and ALT, there is a transient rise, but that comes down by week 3, and from there on out, the mean liver enzymes, AST or ALT, do stay below baseline, whereas GGT has that very rapid decrease, which stays low from about week 5. And because I was looking at the kind of the safety data, and I wanted to be aware of what was going on, I did a bit of a sub-analysis where I pulled out patients who had started with elevated liver enzymes. And as Dr. Mahal said, not all patients will have elevated liver enzymes at the start. So with that in mind, this was about 16 patients who I pulled out, and just for kind of reference, I classified elevated as above 35 in national units per litre for AST and above 45 for ALT. And this was a sub-analysis, and this also showed largely the same pattern, indicating that the people who started with the elevated liver enzymes did much the same in terms of they still saw that liver improvement. They still had that transient rise, but their liver enzymes still came down significantly and stayed down. And one thing I really want to focus on as well is the liver stiffness data. So for various reasons, it wasn't possible to get liver stiffness measurements for everyone. For some people, particularly people who maybe had larger amounts of central adiposity, it just wasn't feasible to get a hugely reliable reading, which is why this is a baseline of 27 rather than baseline of 30, and so on and so forth. We can see that liver stiffness came down. This is also a bit of a sub-analysis. So this was patients who had NASH on biopsy, who also had a successful FibroScan reading. So again, we can see those patients with the confirmed NASH saw significant improvements in their liver stiffness as well, which is really reassuring. And talking a little bit about metabolic data. So obviously, NAFLD is very comorbid with metabolic derangement, as Dr. Mahal talked about. So one of the things that I did want to look at were markers of that. And looking at this, we can see that glucose, HbA1c, and insulin all progressively decreased from baseline to post-VLCD, and those changes were either maintained or further reduced. And at baseline, 46% of patients were using diabetic medication. And at follow-up, that number was down to 35%. Overall, 3 patients had their diabetes medication withdrawn altogether, and a further 5 had their dosage reduced, which just to shed a light on what is actually happening with these patients outside of the numbers. At 9 months, also a good chunk of people had achieved good control of their diabetes if we're classifying HbA1c of less than 48 to be classified as good control. And just to talk now a little bit about the cardiovascular outcomes that we had to look at. So we looked at blood pressure and Q risk score. So we can see that both systolic and diastolic blood pressure reduced and then slightly increased again, but stayed below baseline. And the same pattern was seen with Q risk 2 score. A Q risk 2 score of 10% is in some practices considered to be quite significant, and it's that level of a Q risk 2 score of 10% will be often indicative of potentially being need to prescribe statins or other kind of protective therapy. And so of interest, 19% of patients initially had greater than 10%. So we can see that Q risk 2 fell from greater to 10% to less than 10% for 19% of patients post VLCD, and in 60% of those who completed the 9-month follow-up phase. Data not shown graphically, but waist circumference and hip circumference significantly decreased as well, as did triglyceride scores, but there were no significant changes in other kind of cardiovascular biochemical indicators. So as I mentioned, we also had a look at quality of life. We can see that quality of life significantly increased, weight-related symptom measure significantly decreased throughout, which was really reassuring. And as I talked about a little bit, so I'm not going to spend a long time talking about this, general medication usage did reduce, largely due to anti-diabetic medication, but also antihypertensive medication reduced as well. While this is really reassuring to show that patients had a great time of this, essentially, it is worth noting that there were side effects. However, all these side effects were transient and stopped on stopping the very low calorie diet, the most common of which were constipation, dizziness, headaches, and an increased sensitivity to cold, with numbers shown here. And kind of approaching the end of some of the data, I did have a look at correlations of weight loss with improvements in markers of liver health. And so we can see there that weight loss at follow-up and weight loss at 3 weeks was strongly correlated, i.e. an early weight loss was very predictive of significant weight loss. And in terms of changes in AST, there was a very slight correlation between change in AST and weight loss, and there was a correlation between a change in weight loss and change in NAFLD fibrosis score, similarly so with systolic blood pressure and low density lipoprotein. So overall weight loss at 9 months was associated with reduction in AST, NAFLD fibrosis score, systolic blood pressure, and LDLs. And one last thing quickly to touch on before I finish up is this was a feasibility study. So I did some embedded qualitative interviews with several patients, and I wanted to have a look and see what actually helped them or was difficult for them. And the main things that came out of these interviews, after they were thematically analysed, was that they felt like the opportunity to lose weight rapidly incentivised them to take part. Accountability to healthcare professionals promoted adherence. The intervention, i.e. the VLCD, was really easy to follow. Practical and emotional support from friends, colleagues, and family members really helped with their adherence, and that rapid early weight loss that they saw motivated them to adhere to the intervention. And I think probably actually the most important, shift work made adherence to the VLC difficult, and this could be worth bearing in mind when considering who this intervention might be suitable for. It might be worth talking to people with shift work and seeing actually how this might affect their work and how it could work together. So where next? So as I've alluded to just there, I'm kind of in the throes of doing some qualitative analysis, which should hopefully be out there fairly soon. And this is a great kind of, I think, opportunity to look at some more potential novel kind of biomarker data and try to get a better idea of what's actually happening when we see this level of significant weight loss in NAFLD. But I think most importantly, a lot of the data I've talked about is secondary. These stats aren't powered for it. So potentially where next, we could be looking at a larger trial to really get a good idea of what is happening with these patients and how well this really does work. So overall, a very low calorie diet is feasible to achieve a significant sustained weight loss in some patients with advanced NAFLD. Qualitative findings indicate acceptability and provide recommendations for potentially successful intervention development. And this forms a great basis, hopefully, for a greater mechanistic understanding of the effects of weight loss in NAFLD. And hopefully, we'll be able to shed some light on the effect of fibrotic pathways and the extracellular matrix remodeling pathways, which come into play when thinking about fibrosis. So I will now stop sharing my screen, as I think we're going to go to the Q&A. If I can work out how to stop sharing my screen.
Yes, thank you, Dr. Sprague. So I did push a question through. Oh, I might need you, Dr. Sprague, to turn off your speaker. I think we're getting some. Okay, thank you. So I did push a couple questions through. I will actually go ahead and read them because they might have kind of gotten lost in the chat box. So I think the first one is for you, Dr. Mahal. It says, for some patients with normal BMI and would also like to gain weight by weight training at the same time, what approaches do you suggest for those patients to do to monitor their liver's health in daily life? And do you suggest a weight loss program for those patients?
So yeah, I think that's an excellent question. As a general point, muscle is always good. And obviously, when we speak about total body weight and BMI, that's a very crude and insensitive indicator of someone's total health. So anything that will build muscle, which obviously typically is exercise, is excellent news. So I would encourage, I do encourage all my patients. The reason I didn't highlight it predominantly is that the main pathway to weight loss is nutrition rather than exercise. But exercise is always good news, not just for the liver, but obviously for a multitude of other reasons. So I would encourage patients to exercise. The other point to make regarding, sorry, I'm just gonna lost my train of thought. So regarding exercise is that, Oh, so even with the VLDL, I mean, I've used Optifast extensively. Patients can exercise with Optifast. Okay, so just because someone's in a low-calorie diet doesn't mean they need to rest. In fact, if you look at human physiology, I mean, when we are forced to be without food, and we obviously go into, in the days when we were forced to be without food, and we go into a ketotic state, that is an excellent physiology for exercise. I mean, when people are ketotic, they can run because, in fact, that's what you need to do when you don't have enough food is you need to get up and find food in the old days, right? So exercise, absolutely, and you can exercise on a VLDL diet.
Great, thank you. So that's good to know then, that the VLCD diet does not limit you. So the next one I think is for you, Dr. Scraggs, says, query from a hepatologist. 3-meal replacement with Optifast results in liver fibrosis. What's your point of view on this? So I think the question might be someone who uses 3 meal replacements a day, does it impact liver fibrosis? I think that's the question.
Sorry, I'm not quite 100% sure what the question is.
Yeah.
3-meal replacement.
I think it was maybe clarification of, did you see a change in fibrosis?
Okay.
I think so. Yeah.
I mean, formally, I can't really say so because I didn't do a biopsy before and after. I think the best way we can look at the fibrosis in my study would be looking at the liver stiffness. The liver stiffness, though, is fairly limited in that it gives a blunt number of how stiff the liver is, and it doesn't dissect between what's causing the stiffness. It doesn't say whether that's fibrosis or whether that's fat within the liver. So it's quite blunt in that regard. But what we do know is that a stiffer liver is a less healthy liver. And we saw that liver stiffness reduced. We saw that it reduced in patients who had definite confirmed fibrosis on baseline and therefore presumably potentially afterwards as well. So I can't say for certain that fibrosis reduced because I didn't do a biopsy in my participants, but signs are looking good that there was improvements in functions of the liver, i.e. liver stiffness decreased, liver enzymes often normalized for people and definitely reduced, but I cannot say for certain about whether fibrosis improved as I did not do a biopsy.
Is that something that you think you might look at doing future-wise in another study, having a post-biopsy?
Yes and no. Biopsy is, of course, quite an invasive procedure for patients. So that's a difficult one because in theory, yes, that would be great. It'd be a great way of kind of quantifying any changes that we saw. It is the gold standard for diagnosing NAFLD and NASH. But I think for the sake of kind of wanting patients to take part and stick to it, it's probably not one of the best ways to go. And there are other strategies of quantifying things like liver fat, which could, again, give some information about it, such as an MRI. But as for whether any larger studies may include a biopsy, I think the jury is still out for the time being, as that would really depend on the kind of the overall study design and what it is that we're truly trying to look at, i.e. if the primary outcome would be changes in fibrosis, then yes, probably. If the primary outcome was looking at weight loss or intrahepatic lipid, probably not, because it is quite an invasive procedure.
That makes sense. So the next question is there a difference between weight loss from lifestyle versus weight loss from lifestyle plus anti-obesity medications for reversal of NAFLD? I think that might be to you, Dr. Mahal.
So that's a good question. I mean, my simple answer would be to my best understanding, is no. I mean, it would obviously have to be a head-to-head study, but all the data that's coming out in terms of not even just lifestyle and medications, but even bariatric surgery, but that most of the benefit seems to be from total body weight loss. And as we know, I mean, obviously there are a range of obesity medications and they work very differently. Whether one's speaking about a GLP-1 agonist or speaking about naltrexone. But I would say the overall mechanism of action seems to be total body weight loss.
Okay. So the next question is for you, Dr. Scragg. So in your study, did people with biopsy-proven NASH show better adherence or response to the VLCD?
That's a very good question. In terms of adherence, so quite bluntly, I guess maybe looking at adherence in terms of withdrawing from the study, there was no difference. There was no preference for people who withdrew with those who had biopsy-proven NASH or not. But I think potentially the study maybe didn't have the numbers to answer that because, for example, within the very low-calorie diet phase, we only had 3 dropouts compared to 27 who stayed in. And of those 3, I can't remember off the top of my head, but I think 1 or 2 may have had NASH proven on biopsy, but probably not the numbers to formally assess that, but that would be really interesting going forward. So adherence is a strange one because I had to take their word on how well they were adhering to the very low calorie diet, and I had to use their weight loss as an indicator of that. I guess that links up a little bit to response. And again, when I kind of did any analyses and stratified by people who had biopsy-proven NASH, there was no significant difference really in weight loss if we're using that as a response marker or a marker of adherence. There wasn't really any difference at all, but potentially in a larger study, if there was more numbers, that would be something really interesting to look at formally using statistical means.
Absolutely. You would think that maybe those with NASH might have more motivation to stay with the diet. So the next question I think also is for you. So is it possible to achieve VLCD without the use of meal replacements? And maybe Dr. Mahal might be able to also put his perspective with what he sees in the clinic. I do have clients able to achieve weight loss of 10% or more without the use of meal replacements, but it just takes several folds of time.
I think, yeah, it by all means is achievable without a total diet replacement. I think there are several studies which are food-based which have achieved this. Potentially they, as the answer kind of is in the question a little bit, it may take a little bit longer, or it may take more repeated attempts, or it may be that people, like a lower percentage of people, maybe achieve this 10% weight loss. But I know there are some studies which look specifically at food-based very low calorie diets or low calorie diets, and the results there are promising as well. Is my kind of half of the answer to that.
So I think that's a great question. And I would like to start off by saying that there's a difference in dealing with population data versus individuals. So when dealing with an individual, I never tell anybody that something's impossible because an individual can do almost anything in relation to diet and weight loss. But I do point out to them that, on average with lifestyle changes, we're looking at 3 to 4%. So that's the average, but I don't discourage people by saying, well, you cannot lose 10% by lifestyle changes. But the reality is that when most people approach lifestyle changes, they wildly overestimate what they can achieve. They make lifestyle changes and maybe go to the gym, etc. And they believe, for just reasons that are just intuitive, because of course they don't know the data, that they're going to lose 20, 30 pounds, which of course we know is at a population level is not going to happen. And the real danger from that is that when they lose, the expected 7 to 8 pounds, they view that as a failure. which is, which has a whole range of negative connotations for the individual because they don't know the population data. So, I mean, I never discourage an individual and say, oh, you cannot do X, Y, and Z. But at the same time, it's important to point out to them that on average, people will lose 7 to 8 pounds. And if you lose 7 to 8 pounds, that is a success. Please don't view that as a failure because you had some arbitrary figure of 20 pounds or 25 pounds.
Mm-hmm. And as you kind of showed, weight loss, regardless of the amount, really can have positive impact on
yeah, I mean,
outcomes.
I mean, say even, but 3 to 4% weight loss is clinically significant. I mean, it's we can't show hard data saying fibrosis is reversed, but it's clinically significant. So I never discourage people from either 3 to 4% or say you will never lose 10% without medications. The other point is that what I've seen is that when patients have a diagnosis, if you give them a goal that if you lose X amount, say 10%, and there's a good likelihood that your liver histology will get better, that's a real target they can aim for. Because otherwise it's a question of, well, how long is a piece of string? Like, well, how much weight do I need to lose? So you have to, embed that goal into something that actually matters to the patient, which often in my clinical situation is that, well, you have NASH, but if you lose 7 to 8%, I can tell you with some confidence that your liver will get better, or at the very least, you won't progress to cirrhosis. I have patients who have stage 2 and stage 3 fibrosis, and they're appropriately very concerned about not becoming cirrhotic. So, again, the good news here in the NASH world is they don't need to reach a BMI of 25, which would be almost impossible for somebody with a BMI of 32 to get from 32 to 25. But, 10%, 8 to 10% loss, BMI 32 to 29 can make a huge difference.
Absolutely. So yes, so any weight loss, obviously, clinically significant is important. That's kind of the key word, clinically significant. So the next one I believe also is for you, Dr. Mahal. So when following VLCD, will you measure participants' ketone level? And also, if total energy and protein is very low in VLCD, how would participants maintain their body muscle mass?
That's a good question. So we don't, we measure electrolytes because obviously there can be changes in electrolytes with very low calorie diets, and we also measure liver function tests. So we measure those. We don't measure ketones because I expect ketones to go up. I mean, that's part of the process. So it's not as though if I saw ketones going up, I would stop the diet, right? So we don't measure ketones. Now, in terms of maintaining muscle mass, as I've shown you, and in fact, that paper that I reviewed, I mean, they had a lot of data on there, including muscle mass. I didn't focus on that, but in fact, that slide has data on that. So I think people have asked for a PDF, so you could look up on that. And there may be some loss in muscle mass, but the predominant loss is in body fat. And again, people can absolutely exercise while they are on a VLCD diet, because again, that's what we're physiologically designed to do. When we are in calorie deficit and making ketones, we can run. I mean, that's not the time when our bodies are sort of flat on their back, because essentially that's what we needed to do when we didn't have enough food. We had to go out and catch something. So being in negative calorie balance is entirely consistent with exercise.
I think as well, I completely agree. Potentially maybe of interest to whoever asked this question. In my study, we did measure muscle mass. I measured skeletal muscle mass, and from baseline to post VLCD, it decreased, but not significantly so. However, from baseline to 9-month follow-up, it did decrease, and that was considered to be significant, but not alarmingly. When we looked at the data between myself and the clinical members of the research team, we weren't horrified at how much. It was a very small amount, and it's the kind of thing that if they were encouraged to exercise would rebuild very, very easily. As it happens, we didn't encourage for them to increase their exercise. We just said to them, see how this fits in with your usual lifestyle. If you find that you are a bit fatigued, you might need to knock it down a little bit in terms of how active you are, but don't do nothing. Try it and see. So I think there is probably maybe a good scope out there for maybe post VLCD, depending on how people feel in terms of their energy when they're on it, because everyone is subjective. Some people felt, I know anecdotally from my study, some people said they had never felt so active and awake and they were really energized. Whereas some people said, it was potentially the things like constipation or just not feeling quite 100%. And it was quite varied and it was very individual. So potentially there is a scope or a place for a kind of a resistance exercise training program or something like that to rebuild skeletal muscle mass afterwards if people wanted to, or if they felt they couldn't be as active during, potentially.
But there was no real recommendation for protein kind of after they stopped, increased protein after they stopped the VLCD.
No, we at that point, because the real kind of heart and soul of the study was that initial very low calorie diet, and the follow-up phase was more purely just to see if they could maintain the weight loss that they had achieved. So we did refer some people to exercise on referral, where they could get their kind of induction to a gym and have a reduced fee of exercise for a while, which I think 16 people were referred to and did and really enjoyed. Because they had felt so much more energized for doing this, they wanted to do that afterwards. So we gave them the opportunity to, but that wasn't specifically part of the protocol in any way.
Okay, thank you. The next one, so there's 2 parts. In the interest of time, I'm kind of just going to ask if we do not get to everything, we'll try to see if we can follow up post the presentation. But if we can kind of try to keep some of the answers a little bit shorter. So the next one here is 2 parts. Does the rate of weight loss impact on improvements in NASH and fibrosis? So probably both of you maybe speak on that. So does a 10% weight loss have a different effect if achieved with VLCD quickly or with a moderately caloric restriction over a longer period of time? And 2, is there any data on intermittent fasting versus continuous dieting when energy matched? So probably, is there a difference on the impact of NASH or fibrosis if you do the low calorie or VLCD during intermittent fasting versus just a continuous VLCD? Maybe Dr. Mahal, if you want to talk about.
So those are complicated questions, and essentially at the end of the day, you'd have to do very carefully designed clinical studies to answer those. In terms of the quickly part, the first aspect of it, I would just say that the different pathologies, so steatosis, inflammation, and fibrosis, those 3 different aspects of the liver injury, if you like, they improve at very different rates. So the steatosis and the inflammation can improve relatively quickly, within a few weeks, 6 weeks, something like that. So that's just the biology of it. The fibrosis improvement does take much longer, probably many months, maybe 6 months, 12 months, 18 months, something like that. So so that's that aspect of it. I don't think there's any, this is a chronic disease. There's no urgency to rapidly lose weight in 3 to 6 months. I mean, if people can, that's fine, but there's no urgency in that. So obviously, what's much more important is that people sustain the weight loss, right? I mean, that's the crucial aspect. The other thing I'd like to point out is that patients sometimes feel that if they do it by themselves, that they will continue having weight loss, but as we know with lifestyle changes, people do plateau out relatively quickly, so within the first 2-3 months, they might lose say 3 or 4%, but then the vast majority will plateau out. It's not that then the next 3 months they'll lose another 3% and then they'll lose another 3%, and that's often the biggest shock that patients have, is when I say to them, well, if see the nutritionist, etc., it's very important. Expect to lose 3 or 4%, and they'll say, oh, but then what about after the first few months? So the plateau, unfortunately, does come in, and that's it's not an ongoing 3% every 6 months.
Did you, Dr. Scragg, see anything as far as difference on rate of weight loss, or did you see that everyone, not everyone, but most kind of lost a similar amount of weight in the same period of time?
I think largely most people lost that weight around the same amount of time. And exactly as Dr. Mahal said, it's quite subjective, I guess, how quickly people want to lose weight. So my study was a very low calorie diet, which while we've maybe normalized it a little bit by talking about it so much, I think it needs to be acknowledged that that is a very quick way to lose weight. Compared to lifestyle changes where people may not achieve that level of weight loss, so may not lose weight so rapidly. And because everyone was standardized to the same weight loss kind of protocol in terms of the same very low calorie diet, people lost weight largely at the same rate. So it wasn't really possible to compare who lost it quicker and did they have any different effects compared to those who lost it a bit slower, because overall, everyone lost weight very quickly, given that they were on an 800 calorie a day diet.
I see that we're over time. If both of you wanted to stay on for another minute or two, we have maybe two other kind of quick questions. So the next one here is, when patient has normal triglyceride levels but high in liver enzymes, can it be explained as other types of fatty liver or other factors, for example, antibiotics in clinical practice?
So I think the general point to make is that fatty liver disease, one obviously has to exclude other liver diseases, and that's one of the biggest challenges that I face, is that, I see, dozens and dozens of patients every week with mild liver function test abnormalities. And as we know, 50–60% of the population is overweight. But my first job really is to make sure that it's not something else, right? Because all the other liver diseases are still out there, the autoimmune liver diseases, the genetic liver diseases, and the fact that obviously, medications can cause abnormalities in liver function tests. So, just because somebody has a BMI 32 and has diabetes and has abnormal liver function tests, it definitely does not mean they have NASH. I mean, they could have autoimmune hepatitis or, Wilson disease or something else. And I have to sort of share that with my colleagues all the time, because my biggest fear is that I'll see a patient like that and say, oh, you have NASH, whereas in fact they have autoimmune hepatitis and need to be on steroids. So absolutely, we have to be very cognizant that all the other liver diseases are out there, which is one of the challenges in primary care with this population, that just because somebody has metabolic syndrome and abnormal liver function test, we can't immediately say they have NASH. And it's not that easy to rule out some of the rarer liver diseases.
And remind me, Dr. Scragg, did you look at triglyceride levels in your study?
I did look at triglyceride levels, and they did decrease, but only very marginally. And again, the numbers weren't powered to look at it, but there was a decrease. But as is, I think, often the way with these kind of weight losses and these measures, the triglycerides were actually one of the slower things to fall. So that wasn't something which changed so rapidly as, say, glucose did or the liver enzymes. The triglycerides were a little bit slower to fall, and there wasn't a huge reduction in them either.
Maybe I could just make one other point. So, with diabetes, of course, we're familiar with the fact that high glucose levels are actually directly responsible for the end organ damage, like eye damage and vascular damage. And with, cardiovascular disease, we know that abnormal lipids are directly responsible for atherosclerosis. That's not quite the same true for NASH. So it's not actually the high glucose, for example, in diabetes that's causing the NASH. The disease process is quite different. So it's important to look at features like hemoglobin A1C and the lipid profile, but these changes are not, these abnormalities are not actually causing the liver disease. We don't have an absolutely clear understanding of what the actual liver disease is. So, for example, a diabetic patient is insulin resistant, and they could have excellent control of their glucose, but they'll still develop NASH. So it's not the glucose control that's actually crucial for NASH.
Thank you. All right. Well, I do want to be respectful of everyone's time. I appreciate everyone staying on. I'd like to thank all of the participants for their interest in taking the time to attend this webinar. And as I mentioned, we will try to address some of the additional questions that did not get answered. We'll probably try to follow up on them. We do have contact information. And so I thank everyone, and I hope everyone has a great rest of your day or evening. All right. Bye. Thank you.